Hello everyone, I'm Dr. Divya Madan. Welcome back to my YouTube channel. So INICET CT exam just happened, and here's my take on the recall questions of pediatrics. So overall analysis of this exam was a lot of repeat questions, a lot of previous year topics, and for pediatrics there was odd 15-20 questions, which is a lot. So let's begin with the recall session. So the first question here was the rate of increase in the head circumference in infants less than 3 months of age is 0.5 centimeter per month, 1 centimeter per month, 2 centimeter per month, or 4 centimeter per month, right? So we all know that if we talk about head circumference, how do we measure the head circumference? We take a measuring tape and place the tape over the head of the child in such a way that posteriorly it touches down towards the highest point on the occiput, and anteriorly it should be just above the supraorbital ridge, right? So the normal head circumference at birth is 33 to 35 centimeter. That is 65 to 70% of the adult head size, right? If we talk about the increase in the head circumference after birth, then in the first 3 months it's 2 centimeter per month. In the next 3 months, that is 3 months to 6 months of age, it's 1 centimeter per month. And in 6 months to 12 months of age, over the next 6 months, it's 0.5 centimeter per month, right? So it was a straight away question where they asked rate of the increase in HC in the first 3 months of life, right? So the answer straight away here is 0.2 centimeters per month, 2 centimeters per month, right? So moving on to the next question. It's about a 6-year-old boy. Some anthropometric measurements were given. His weight for age was -2 standard deviations, height for age -2.5 standard deviation, weight for height -1.7 standard deviation, and they asked us to interpret this finding, right? And the options we had were severe acute malnutrition, chronic malnutrition, acute and chronic malnutrition, or moderate acute malnutrition. So first of all, we all understand that if your finding is lying anywhere across ±2 standard deviation, that is considered to be abnormal, and the only exception here is that of microcephaly, right? Microcephaly, small head. There the cutoff is -3 standard deviation. In rest all conditions, something beyond ±2 standard deviation is going to be abnormal, and anything beyond -3 standard deviation or +3 standard deviation is going to be severely abnormal, right? So firstly, let's talk about weight for age. We all understand that weight for age is something which is common to both chronic as well as acute malnutrition, right? So they have given us weight for age less than -3 standard deviation. So this child is actually severely malnourished. This could be chronic malnutrition also, acute malnutrition also. The second point is weight for age. Second point is height for age. We all understand height for age, if less than -2 standard deviation, is stunting, and less than -3 standard deviation is severe stunting, right? And this stunting is a marker of chronic malnutrition. So you can see here that it is less than -2 standard deviation. So this child is stunted. That means this child has chronic malnutrition also. Now let's talk about weight for height, which is more appropriate for acute malnutrition, right? Acute malnutrition, whenever there is an acute insult, my weight would be affected first and my height would be affected later on, right? So weight for height here would be less than -2 standard deviation, which is given over here, right? So this child is also wasted. That means this child also has a component of acute malnutrition. So according to these findings, if we talk about severe acute malnutrition, how do we define severe acute malnutrition? Severe acute malnutrition is defined as any one of the following: weight for height less than -3 standard deviation. Second would be MUAC less than 11.5 centimeter. And the third is edema, symmetrical edema without excluding other causes, nutritional edema, right? We want any one thing out of these. So here it satisfies this criteria, weight for height less than -3 standard deviation or not? Does it satisfy that? No, it doesn't, because my child is lying on -1.7, right? So being on 1.7, it is above -2 standard deviation, so it won't be considered as severe acute malnutrition. Chronic malnutrition is correct. I can see stunting over here. Moderate acute malnutrition won't be in this category. The most appropriate here would be acute on chronic malnutrition, right? So moving on to the next question. There was a 15-year-old child with short stature. The height is given as 145 centimeter. His upper segment lower segment ratio is 0.8:1. What would be the diagnosis here? I have a detailed video on approach to short stature. If you want to watch that entire video, you can explore my channel. We have an explanation on short stature as well. Here, what is important for us in evaluation of short stature is upper segment lower segment ratio, because on the basis of this upper segment lower segment ratio, we decide whether this is a proportionate short stature or whether this is a disproportionate short stature, right? If you have seen a newborn baby, then you can easily imagine that the head is big as compared to the body, and as we grow, our trunk grows, our limb grow, right? So what is upper segment? Upper segment is the height from the top of the head till pubic symphysis, and my lower segment is minusing my overall height from this upper segment. That would be from my pubic symphysis till my foot, right? So this is normal upper segment lower segment ratio. So you can imagine that as the child grows, my lower segment will increase as compared to the upper segment. So this ratio is going to decrease or increase? This ratio is going to decrease. Initially my upper segment is big, and as I grow, my limbs also grow, so my lower segment also grows. So this overall ratio of upper segment lower segment ratio, that ratio is going to decrease. So the normal ratio at birth is 1.7:1, and at 3 years of age it is 1.3:1. At 6 years of age it is 1.1:1, and at 10 years of age it becomes 1:1, and after that adult ratio is achieved, that is 0.9:1, also written as 1:1.1, right? So here we have a 16-year-old boy, so the ratio should be the adult ratio, that is 0.9:1, but here the ratio is 0.8:1. That means the normal, I know, at this age should be 0.9:1. Here the ratio is even lesser. That means here I have decreased upper segment lower segment ratio. My upper segment is decreased, so this child has something known as short trunk dwarfism, right? Short trunk dwarfism is seen whenever my spinal structures are affected in some way, like pot spine, spondyloepiphyseal dysplasia, storage disorders, mucopolysaccharidosis, right? So let's look at the options. In options we have achondroplasia, hypothyroidism, spondyloepiphyseal dysplasia, and growth hormone deficiency. So straight away, short trunk dwarfism, the answer should be spondyloepiphyseal dysplasia. At the same time, you should know that if upper segment ratio is more than expected for that age, that means the trunk is of normal size but my lower segment is short, this would be short limb dwarfism. And remember the 3 conditions where you should see this short limb dwarfism. You should remember this even in your sleep. 3 conditions are rickets, achondroplasia, and congenital hypothyroidism, right? So here in the first 2 conditions, achondroplasia and hypothyroidism, I have increased upper segment lower segment ratio, that is short limb dwarfism. And lastly, growth hormone deficiency affects my trunk as well as my limbs equally, so I am going to have a proportionate short stature, not a disproportionate short stature. So here I am going to have a normal upper segment lower segment ratio, right? So remember, whenever we evaluate children with short stature, we check for upper segment lower segment ratio If that upper segment lower segment ratio is normal for that particular age, then the child has proportionate short stature. On the other hand, if this upper segment lower segment ratio is either increased or decreased, then it comes under disproportionate short stature. Remember, if the upper segment lower segment ratio is increased, that means the child has a bigger trunk and shorter limbs. This is short limb dwarfism. Three important conditions for us are achondroplasia, rickets, and congenital hypothyroidism. On the other hand, if the upper segment lower segment ratio is decreased, that means my trunk is shorter. This is short trunk dwarfism, and I have all those conditions where my spine is affected, like spondyloepiphyseal dysplasia, vertebral anomalies, pot spine, mucopolysaccharidosis, right? So very straight away question here, the answer was spondyloepiphyseal dysplasia. Moving on to the next question. All of the following could be seen in nutritional rickets except normal calcium, low phosphate, urine calcium to creatinine ratio of more than 15, and high PTH levels, right? So firstly, what happens in nutritional rickets? We have vitamin D deficiency happening, right? Vitamin D is very important for us because it helps the absorption of calcium and phosphate from the gut. It activates the kidneys also to produce more absorption of calcium and phosphate, right? So whenever there is nutritional rickets, I'm going to have low calcium, and in response to that low calcium, the calcium sensing receptors over my parathyroid glands gets activated, and there is release of parathyroid hormone. This parathyroid hormone, what it does? It causes release of calcium and phosphate from the bones, right? Secondarily, what it does? It causes increase in the production of the active form of vitamin D, 125 DHCC, that will further increase the calcium and phosphate absorption. And at the same time, it causes excretion of the phosphate through kidneys, phosphate excretion through the kidneys, right? So whenever you have nutritional rickets, you are going to have a low phosphate, true. Because of the action of parathyroid hormone, there is increase in the absorption of calcium as well as release of the calcium. So in nutritional rickets, I can have low to normal calcium. So this is also true. High PTH is also true. At the same time, high level of alkaline phosphatase is also true. In fact, raised ALP levels are considered as a hallmark for nutritional rickets. If you don't have raised ALP, the nutritional rickets vitamin D deficiency can be virtually ruled out, right? So the most appropriate answer here is going to be urine calcium to creatinine ratio more than 15, because calcium absorption takes place, not excretion from the kidneys, right? So this would be the most appropriate option here. We do not see increased urine calcium to creatinine ratio. In fact, decreased calcium to creatinine ratio would be seen. So moving on to the next question. Best indicator of some dehydration in SAM is? Remember, in SAM babies, because they have lost subcutaneous fat, a lot of signs of dehydration could be misinterpreted, right? In most of these SAM babies, as they don't have that subcutaneous fat, they look more dehydrated than they actually are, right? So sometimes we overestimate the degree of hydration. These children, because of the loss of subcutaneous fat over face, their eyes could appear sunken. Also, on performing skin pinch, as they don't have subcutaneous fat, the skin pinch is always slower. So the most reliable here for some dehydration would be nothing but thirst, the level of thirst, right? In thirst, if the child is thirsty, aggressively drinks water, that's indicative of some dehydration in SAM babies. Rest other factors like sunken eyes, lethargy, skin pinch could be erroneous here because of the degree of malnutrition in these babies. Moving on to the next question, again a dehydration question. A 5-year-old child presents with symptoms of mild to moderate dehydration. You are evaluating the degree of dehydration. Which of the following clinical signs would be consistent with some dehydration over here? Decreased urine output, lethargy, delayed skin pinch, or sunken balls? They are asking us some dehydration, right? So do we see decreased urine output and some dehydration? Yes. Lethargy, no, the child is very irritable. Lethargy is seen in severe dehydration. Delayed skin pinch, true. Sunken eyeballs, true, right? So 1, 3 and 4 are correct over here. Moving on to the next question, straight away question, which fluid solution is preferred for pediatric patient? Nelson 22nd edition clearly states that DNS that has 5% dextrose along with NS, normal saline, that is 0.9% NaCl is the fluid of choice. Along with that we add potassium 1 milliequivalent per 100 ml, right? So the answer correct would be NS 5 dextrose. Moving on to the next question, when to start steroids in Hinosh-Schulin purpura? Hinosh-Schulin purpura is a self-limiting condition, so we don't usually give steroids, but whenever there is severe GI involvement, we give steroids. So let us look into the question. The options are severe skin rash, arthritis, GI bleeding, severe abdominal pain. So these two options are confusing here. Both indicate severe GI involvement, but if I have to pick one, that could be option D, that is severe abdominal pain, right? Now moving to the next question, another repeat question, very favorite question of both NEET as well as INI. Which factor does not contribute to the fetal growth in the uterus? Right, post birth it's the growth hormone that plays a very important role in growth, but before birth growth hormone plays little to no role in the growth, right? So the answer here straight away is growth hormone. Growth hormone does not contribute to the fetal growth in uterus. Insulin, thyroxine, very important factors, and insulin further acts by the mechanism where insulin like growth factor is the mediator, so option C would also be correct. So growth hormone does not contribute to the fetal growth. After the birth, growth hormone plays an important role. That's why in children that present with growth hormone deficiency usually are normal at birth, and the growth retardation is appreciated after 1 year of birth, right? So let's move on to the next question. INSURE is associated with which condition? Respiratory distress syndrome, birth asphyxia, neonatal jaundice, cyanotic spell. INSURE stands for intubate, surfactant, and extubate, right? INSURE is the technique by which you give surfactant in babies with respiratory distress syndrome or hyaline membrane disease. We remember that preterm babies, they are born very prematurely, so their surfactant in the lungs is not very mature. That's why in these premature babies they have respiratory distress syndrome due to the lack of mature surfactant. And in those babies we give surfactant from outside, and one of the techniques to give that surfactant is INSURE technique. We'll intubate the baby, give surfactant through that endotracheal tube, and then extubate the baby. This is INSURE technique. Other techniques include LISA, that is lesser invasive surfactant administration, where instead of inserting that big endotracheal tube, we insert a small feeding tube, less invasive. Or we have MIST, that is minimally invasive surfactant therapy, where surfactant is given through nebulization, right? So the best answer here is nothing but respiratory distress syndrome or hyaline membrane disease, that is appreciated in preterms, right? Now moving on to the next question. The next question was about cerebral palsy, and this is something that I teach in class with very eagerness, because I believe in some form or the other they ask questions about CP, especially in INI exam. So this time they asked that spastic quadriplegia develops in a child with, options are periventricular leukomalacia, cystic encephalomalacia, basal ganglia calcification, or cerebellum degeneration, right? If you talk about brain injury in pediatric population, in the neonatal population, brain injury I can appreciate in preterms babies, where the primary brain injury is due to IVH, intraventricular hemorrhage, because of the presence of germinal matrix. So if intraventricular hemorrhage is there, so there could be damage of the parenchyma surrounding the ventricles. So these children are going to have periventricular leukomalacia in the future, right? On the other hand, if we talk about term babies, the primary brain injury in them happens due to perinatal asphyxia. The baby did not cry at birth and had perinatal asphyxia. So this baby parasagittal area would be affected, right? Parasagittal area would be affected. So this child is going to develop parasagittal area infarcts that progresses towards development of cystic encephalomalacia. Right? Having understood this, let's look at into the motor homunculus. We understand the sagittal thing, and we understand we have two lateral ventricles in the midline, right? So if in preterm babies, as we discussed, there is intraventricular hemorrhage, so this paraventricular area would be affected. So that means my lower limbs would be affected. So my preterms with periventricular leukomalacia are going to develop spastic diplegia, where my lower limbs would be affected. Right? On the other hand, if we talk about term babies with the parasagittal infarction, so my parasagittal area would be affected. That means both my lower limb as well as upper limbs would be affected. So my term babies are going to have spastic quadriplegia, right? So they were asking about spastic quadriplegia, that is seen as cystic encephalomalacia. Apart from that, let's look at the other options. Basal ganglia calcification. Basal ganglia involvement is seen in kernicterus formation. So this child would have dystonic CP associated with kernicterus, and cerebellum degeneration would be associated with cerebellar ataxia and other cerebral signs, right? So this completes our question number 11. Let's move on to the next question. Kawasaki disease. They never fail to not ask Kawasaki disease, right? So they always ask Kawasaki disease in the exam hall. I remember the past two papers also, the May 23 paper as well as the November 23 paper, they have asked Kawasaki. Here also they asked about Kawasaki. So the question is, which of the following is not a feature of Kawasaki disease? And the options were strawberry tongue. Strawberry tongue is a feature. Purulent conjunctivitis. Purulent conjunctivitis is not a feature. We see non-purulent conjunctivitis. Polymorphic rash seen. Cervical lymphadenopathy seen. Right? So this is a typical baby with Kawasaki disease. We have non-purulent conjunctivitis, strawberry tongue, cervical lymphadenopathy, peeling and desquamation of skin over the palms and soles, and very irritable child. Right? And the mnemonic to remember the features are green. We say Kawasaki disease if the fever is more than 5 days. Along with that, 4 out of the 5. Cream C stands for conjunctivitis, that is a non-exudative or non-purulent conjunctivitis. R is for rash, which is a polymorphous non-vesicular rash. E is for edema of hands and feet. A is for adenopathy, often cervical unilateral lymphadenopathy, and the size is more than 1.5 centimeter. And lastly, we have mucosal involvement with erythema, fissures, crusting. Right? So this is Kawasaki disease. Let's move on to the next question. Which of the following are the components of Downey score? When I heard about this question, I remembered my AIIMS SR exam. This was asked in the AIIMS SR exam of Pediatrics, and they have picked this question from there only. So what of the following is the components of Downey score? First, respiratory rate, feeding, grunting, cyanosis. So if you look at the Downey score, I usually tell my students in the class that to remember the components of Downey score, the mnemonic is GRACE. G is for grunting, R is for respiratory rate, A is for air entry, C for cyanosis, and R for retractions, right? So let's look into the options. I know grunting, respiratory rate is the feature, feeding is not, grunting is, cyanosis is. So 1, 3 and 4. Option B is correct. Right? So let's move on to the next question. Free flow oxygen can be given by all except self-inflating bag, tail reservoir of the self-inflating bag, face mask, or tubing over mouth. Tubing over mouth and face mask is straight away yes. Now let's talk about self-inflating bag. We all understand how a self-inflating bag functions, right? So we have a valve over here. If you press the bag, this bag will push air forward, and as soon as you leave it, this self-inflating bag will inflate back on, and further air entry is prohibited from that patient end because of the presence of valve. So free flow cannot be maintained here. You have to continuously press that, and once all the air in the reservoir is over, no more air would be pushed back, the bag reinflates. So this is wrong, but the tail end can give the continuous direct flow, right? So the option here would be so correct answer here would be self-inflating bag. Self-inflating bag cannot give free flow oxygen. Moving on to the next question. Febrile Caesar question, another favorite question of both INICET as well as NEET PG people. So in overall, this was a very frequently asked questions paper, previous year topics, previous year questions. You just need to go through the previous year questions, and I believe more than 90% of the questions are good to go, right? So they are asking what is not true about febrile seizure. The first option is 54% recurrence rate, which is not true. The recurrence rate depends upon various factors, and 54% generalized statement is false. Age 6 months to 5 years, true. In simple febrile seizure, the duration is less than 15 minutes and 1 episode in 24 hours, which is true. No need for long-term anti-epileptics in simple febrile seizure, which is again true. So the incorrect option here is 54% of recurrence, right? So here we complete our discussion of the recent INI May exam. I hope a lot of you would have learned by now that it is very important to revise previous year topics, and a lot of questions were actually covered in my notes. In fact, 100% strike rate was there from my class notes, indicating again that it is just the previous year topics that you need to revise again. If you want to have a look towards my notes, then I have dropped a link down below in the description box. There is a set of notes that I used in my preparation. The site is www.ptr.com. If you want to check out those notes, they are available over there. You can check them out. And if you have any doubt regarding any of these questions, feel free to comment down in the comment section below, and I'll be happy to answer them and help you.